Got it. We're being live streamed. Hello, everybody on Facebook and all of our participants are. Oh, let me make sure we're actually on Facebook. We have a little problem here. Hold on, we're going to figure it out. Technology, there's always somebody screwing it up, and tonight it appears to be me.
I just got a notification. We are live on Facebook.
Okay. Yep, we're live on Facebook, but I got a message saying it was an unsupported request. Okay, so Facebook, hi, we're here. Welcome to HCMA's Bighearted Warrior Tour at this stop, University of Pennsylvania. So the East Coast is very well represented tonight, with us being in New Jersey, Julie being in Pennsylvania, and UPenn being down towards Philly. So we've got the East Coast covered. Tonight, we are going to have a number of presentations. After each, there will be Q&A. Only those who are participating in the Zoom room can participate in the Q&A. We do not take questions from Facebook, but we stream there to make life easier on others who wanted to watch but didn't register in time. It's not too late to register. You can go online right now and register and join us in the Zoom room at any time. So I want to do some introductions of my team, and then I'm going to hand it off to the other team. So I'm Lisa Salberg, founder and CEO of the Hypertrophic Cardiomyopathy Association. And with me tonight in the capacity of Center of Excellence Coordinator is Stacy Titus.
Good evening, everybody.
And Julie Russo is our volunteer coordinator. And I don't know if I'm pointing to the right sides of the screens on how I appear on your screen. So if you have any technical problems throughout the evening, whether you're a panelist or you're a participant, you can use the chat feature, and Julie and Stacy will help figure out whatever the little problems might be. So with that, I'm going to introduce Anjali Owens, who is going to introduce her team.
Great. Thank you so much, Lisa. And thanks for the invitation to be here today. Thanks everyone for joining us on Facebook. We have an action-packed agenda that will take us over the next couple of hours. And I'll start by just sharing a slide showing our team as an introduction. And they should be popping up for you soon. Hopefully you can see them. So we started our center when I finished fellowship, which was way back in 2011. I trained here at the University of Pennsylvania in general cardiology, then spent some time at Stanford at their Center for Inherited Cardiovascular Disease under Ewan Ashley's tutelage, and then started our Center for Inherited Cardiovascular Disease in 2011. Under that umbrella is our HCM program, which became a center of excellence with Lisa's designation several years ago now. Seems like a long time, but it hasn't been that many years. And I started as the medical director. My partner, the scientific director of the center, is Kiran Musunuru, who you can see here on the top of the slide. And over the years, we have been able to recruit, hire, train a number of other physician partners who see patients with us in clinic. So I'll do some brief introductions prior to the talk. So starting on the left is Dr. Ken Margulies. He is a physician who sees patients in clinic. He's also a scientist. He's a heart failure transplant physician. And he started with me at the beginning of seeing patients in the clinic. We were fortunate to recruit Charlene Day several years ago. Dr. Day is an internationally recognized expert in HCM. She was part of the guideline writing committee for the AHA and ACC guidelines that were recently put out. And she's here tonight to talk to us about one of her passions, which is exercise in HCM. Dr. Nosheen Riza is next on the list here in the middle. Dr. Riza is also with us tonight as a speaker. She'll be talking about heart failure and advanced heart failure in HCM. She trained here at the University of Pennsylvania. She also is a bona fide advanced heart failure transplant physician. Next is Teresa Wang. Dr. Wang joined us just a couple of years ago. In addition to HCM and heart failure transplant, she has an interest in muscular dystrophies and is also growing that part of our program. Following Teresa, we recruited Dr. Alejandro de Feria. He is with us tonight, and he will be talking about atrial fibrillation in HCM. Alex did a very unique fellowship where he spent a dedicated year seeing only patients with inherited forms of cardiomyopathy, and the vast majority of patients had hypertrophic cardiomyopathy, and he designed his own very unique curriculum to get a lot of genetic exposure, a lot of patient exposure, and also is an expert in cardiovascular imaging. So he is our go-to for looking at echoes, looking at MRIs. Next is Amy Marzolf. Amy was unable to be with us tonight, but I will share her slides. She is our really the boss in charge. She's our lead nurse practitioner. She's been with me since 2015 and is just really a phenomenal advocate for our patients and navigates the system like no other. Dr. Pavanat Luri is our cardiothoracic surgeon. He runs our myectomy program, is also a mitral valve surgery expert and a surgeon who does VADS and transplant. Dr. Howard Herman is an interventional cardiologist. He's a mentor to me, was here when I was training as a fellow, one of the pioneers in alcohol septal ablation, and he does that procedure for many of our patients. On the bottom row is Dr. Kimberly Lin. She's with us tonight. She runs our pediatric HCM program and also is the director of cardiomyopathy there. She's also a heart failure transplant cardiologist. Dr. Ferrari, another mentor of mine, has been here for years in cardiovascular imaging, and he is an imaging specialist. He helps us to look at patients' anatomy prior to surgery. That's one of his areas of expertise. Dr. Deo is one of our electrophysiologists. He sees patients with HCM, but also patients with other inherited forms of arrhythmias. And Dr. Jane is one of our scientists. He and Dr. Musunuru spend most of their time in the lab and writing multi-million-dollar NIH grants. The rest of our team includes 3 dedicated genetic counselors. So this is different and unique from a lot of programs. We have 3 genetic counselors who are embedded in our clinics. They only see heart patients. Jessica Chowns is with us tonight, and she'll be giving a talk about genetic testing. Lily Hoffman-Andrews and Lacey Mayer are also genetic counselors. Then we have our nursing team. So in addition to Amy, we have Nicole Hornsby, another nurse practitioner, Laura Delfs, Linda Wells, Deepti Matthew, and Jessica Boland. So 4 dedicated nurses for our program. And in addition, we have an administrative team, including our program manager, Gabrielle. Shalimar and Giovanna are our administrative assistants, and we have an entire research team that includes research coordinators and a research manager. So I will stop with those introductions and turn it back to Lisa.
Wow, you have a really big team.
And we take care of over 3,000 patients at this point. So it takes a village.
And you even pilfered them from other HCM centers around the country.
Yes.
That's a smart strategy. Okay, I am going to now not have technical difficulties. I'm going to put myself into present mode. There's so much going on here at the HCMA as it is Heart Month. I just want to make sure I tell everybody what's going on and get everybody ready for the events that are about to happen. So again, this is our Bighearted Warrior Tour. And so if you've been to a few of these before, you're going to see some new slide deck. We've got some work that we're doing here. So this is our agenda for tonight. You're going to hear all of these talks. Again, Amy won't be here presenting, but Anjali will take care of that. We need to thank our event sponsors. We have Imbria, Tenaya Therapeutics, Bristol Myers Squibb, and Cytokinetics, who make educational programming for patients possible through their support. So thank you to the sponsors. We appreciate you. So it is Heart Month. So that basically means the team doesn't sleep, and we work really hard to ensure our messaging is getting out. So this is our HCM Awareness Day logo for 2022. HCM Awareness Day will always be the 4th Wednesday of February. So we may not start Heart Month out with a lot of activity, but we have our social media sharing HCM Warrior of the Day all month and much more. We've also been working on state-based resolutions and proclamations and even some laws to have HCM Awareness Day recognized. Julie has to help me with this list here. So I will do what I remember and you fill in the rest. We have a law in Ohio. We have a resolution. What? One? Okay, you're counting for me. Okay, so that one. We have Colorado with a resolution, Texas with a resolution, Connecticut with a resolution, Iowa with a resolution, New York with a resolution, Massachusetts pending, Utah pending. Julie, what did I forget?
Indiana.
Indiana. I'm sorry, Indiana.
And thank you,
Um,
Indiana, and all the
And
other
thank you,
states.
Indiana. So these are really important steps to help us enter a deeper dialogue with these states on things like the Healthy Cardiac Monitoring Act, embedding cardiac questions into well child examinations so we can identify families at risk earlier. So we thank all of those who have helped us get these resolutions passed. We have many more to go. We're trying to get as many done for this year as possible. But if we don't get them in this cycle, we'll get them for next year to put us on their calendar and recognize us there. So this gives us a platform. One of the other great things that has happened during Heart Month, or actually a little bit before, was the release of the movie A Man Called Otto. I think that's my next slide. Yes. Oh, there, we had it on the next slide. I could have just gone to the next slide. We did a viewing of A Man Called Otto here in New Jersey on February 2nd. For those of you who don't know the significance of that day, that's my transplant anniversary. So we all met for a movie. We watched Otto together, and then we discussed the movie and the themes of the movie and how he portrayed Otto Anderson with hypertrophic cardiomyopathy. So thank you, Tom Hanks, for that. We just hope that you would have showed up at the viewing, but we understand you're busy. We're going to be doing another viewing in California in the San Francisco area. It is open. Their seats are limited. We already have about 55 people signed up. If you're in the South San Francisco area and want to come join us for a movie, we have seats still available, and we will be there on Friday, February 24th. So come join us. We would love to see you, and it's on us, and we're buying the popcorn and the soda or water, whatever you want. So please join us for that. What the Healthy Cardiac Monitoring Act is, that I mentioned briefly before, is a systematic, reproducible, and cost-effective way to encourage families to discuss their heart health history and the children's symptoms within a well child examination with their chosen healthcare provider in the confines of the doctor's office, not at a community-based event that requires infrastructure and setup each time you do it. So if we can have the doctors asking the right questions and the patients responding with answers, because we're going to help train people what they're looking for in their heart health history, we can get more people to early diagnosis. And part of the Healthy Cardiac Monitoring Act requires medical education through an online portal where they can learn about the diseases, not just HCM, DCM, ARVC, channelopathies, other inherited diseases, and those that might be congenital. So we're looking for all of these to assist families in getting diagnosed. We're not going to catch 100%, but we're going to do a heck of a lot better than we're currently doing in our current system. So we encourage you all to get on board with us and sign on letters and speak to your state legislators. So the other thing I wanted to tell you tonight is a little bit about our HCM Patient Journey Registry. For 27 years, I've been talking to all of you great people with HCM and kind of taking notes so that the next time you called in, I knew where we were starting from. Well, we're taking that database and we're formalizing it into a patient experience registry. It's different than other registries that are out there because it's going to have a different angle of how we're collecting data, because it's going to be straight from the patient without a lot of other barriers involved. So you're going to be questioned. We're going to have surveys. There's going to be consent process. It's going to be under IRB, supervision. It's developing out quite nicely. We have a medical affairs committee that's monitoring this, and we are looking for some interesting findings out of our experience to help define HCM care a little bit better. One of the things we started doing in the new registry as it was launched at the beginning of the year is we started asking patients questions in a slightly different way. New York Heart Association class is a scale that is used by clinicians to identify what type of heart failure you have and how severe it is. But as anybody who spent any time in HCM knows, it's kind of a bouncing ball because some days were good and some days were bad and some days were average. So we started asking patients, on a good day, how do you feel? On an average day, how do you feel? And on a bad day, how do you feel? And not surprisingly, out of the first 37 individuals we spoke to, only 5 individuals were consistently in one New York Heart Association class. 2 of them were 1s, 2 of them were 2s, and 1 was a 3. But the rest of people On a good day, they might be a 1. On an average day, they might be a 2. And on a bad day, they might be a class 3 or 4. So why is this important? Because as we're developing clinical trials, one of the endpoints that is looked at by FDA and other regulatory bodies is, was there an improvement in New York Heart Association class? So depending upon the day you report to your physician, it might not be accurate, and the drug might actually be much more, or the therapy, not drug, but therapy might be more effective because maybe it stabilized your heart association class, and maybe you don't go from a 1 to a 2 to a 3. Maybe you're a 2 more specifically, or maybe you're a 1. So we want to be able to measure that appropriately. And we feel that we have a unique point of view here at the HCMA, and the patients have a unique input. So maybe we can figure out how to communicate this to clinical trialists, to the FDA, and really help develop meaningful endpoints to the community, as well as to the clinician and the researcher and the pharma company. So we're coming to the table in a new and interesting way. Another thing that we're working on is the fact that Heart Month is not only Heart Month, it's Black History Month. And we have to recognize that within the HCM communities around the country, there's estimated 90% of patients seen in HCMA programs are Caucasian. And this does not represent the demographics of HCM in the general population. There are many Black, brown families who have HCM. We need to find them and get them engaged in high volume care. So this is what the racial breakup of this country will look like in a couple more years. And if you look at this bar here, this is where we are around today. And over a period of time, the Caucasian population or the white population is going to be less common, and these other groups are going to grow. So we need to make sure that we're making plans to integrate all people in HCMA recognized Center of Excellence care models and ensuring that all get the highest level of care. So one of the things that we're doing to hopefully meet this goal is we're developing something called the All Hearts Collaborative, which is a community outreach endeavor to go into predominantly underserved communities. And in this case, they do happen to be Black and brown communities. And we want to talk about their heart health. And we're not only talking about hypertrophic cardiomyopathy to this group, we're talking about hypertension and amyloidosis. Now, that's not our bailiwick. That's not where we spend most of our time, but we have great partners that we're bringing to the table. And that's why it's under the banner of All Hearts Collaborative, because other organizations are going to be joining with us. These grants are going out right now for funding. So we hope to bring a pilot program to 30 different religious institutions. They're Baptist churches in 5 different cities. And if the project works, then we have the ability to go further with it. It is not an inexpensive endeavor. That's why it's taking a number of partners to put this together, but we're looking forward to hopefully getting this launched mid-year. I bring this to everybody's attention because I want to tell a story here very quickly. Derek Armstead was a young man lost to hypertrophic cardiomyopathy without the opportunity of being diagnosed in advance, even though he survived a syncopal episode that actually looked like it was a cardiac arrest that he spontaneously responded from or recovered from. And 5 days later, he did not survive the cardiac arrest. That little baby that he's cuddling in that picture, he had just walked him up a flight of stairs, put down the baby carrier, and arrested. He was 27 years old, and he had a family history of an early death of his mother, who also passed away in her late 20s. But nobody had ever screened his heart, and nobody ever thought of his heart when he showed up in the emergency room at the first event. We need to make sure those who are out in the community from all races understand HCM is something they need to know about. So we do this in his memory. We have some new initiatives coming up here at the HCMA. We have a project that we've submitted for funding using AI technology to help develop better signals to identify HCM off of EKG signaling and other imaging. So cross your fingers that that one gets funded. We have so many new partnerships and wonderful partners to help us bring some of these projects to fruition. We're really thrilled to be working with them. And we have a new media firm that we started working with in January, Meki Media. So we're trying to get more stories out. In fact, I just approved a press release that goes out tomorrow about HCM Awareness Day. So we're trying to get the word out big and broad. For those of you who are watching, and you'll hear me always talk about Center of Excellence and why they matter, and you say, but there's not one in my neighborhood and I can't afford to get there. We have solved that problem too. We have developed the Lori Fund, which provides micro travel grants to patients seeking care at Centers of Excellence. There are financial requirements to get the funding, but please complete the application if you think you qualify. All we do is call the center and make sure that you do have an appointment and that you have met that appointment. We're not inquiring about what happens during your appointment. We just want to make sure that you go. So this $600 can be used for air travel, trains, planes, automobiles. It can be hotel rooms. It can be food on the road. It can be parking. Anything that you find a barrier financially to getting to that center, you have $600 a year sitting in a bank here that if you qualify could be yours if you need it. So please do not hesitate to apply. We're going to talk about this on HCM Awareness Day, so I'm going to be brief here tonight. We have a new online challenge. It is called Drill Dr. Heart. As we all know, sudden cardiac arrest made mainstream television a couple of weeks ago when Damar went down with his cardiac arrest on an NFL field. And thankfully, we're all talking about sudden cardiac arrest preparedness. The Drill Dr. Heart Challenge is not teaching CPR or AED use. Those things are really important and you need to do them before you do the challenge, but it's actually acting out or drilling what would happen if somebody went down in your place of work, your team, your school, your house of worship, your community event. If somebody goes down, does everybody know what needs to be done? We want to develop some muscle memory here. We want people to really practice, call 911, start CPR, get the AED, have somebody outside ready to bring in EMS if there's enough people available. So we're not delaying in any way. So the challenge is plan it, practice it, film it, post it, engage it. So if you want to drill your cardiac arrest for your school, for your team, for your place of worship, wherever, whatever community you want to do, you can apply under each category. And the winner with the most engagements on April 23rd, 2023 will win an AED for their organization. So it can be small businesses, it can be community events. There will be some documentation of where the AED will be placed. And we are very grateful to Defib Tech for being our sponsor here on this endeavor. So if you want to win an AED for your organization, we have made it possible. All you have to do is do the drill, put it out there, and then we're going to passively educate people when they watch your video. Oh, that's what I do if there's a cardiac arrest emergency, and they'll learn by watching you. So help continue that chain of survival to get us to where we need to be. So here's the imagery, the chart. You plan the drill, you practice the drill, you film it, and you enter to win. So you can get that information at 4hcm.org. If you need any printed material, if you want to do a community health fair, a child's health fair, call us. We'll send you whatever you want. We got great posters. We got all kinds of fun stuff here. So we'll send that on out to you. And we're making little stickers for kids coming up. We made Mr. Bighearted. He's cute. You'll get to meet him soon. Tales from the Heart, a podcast, Fridays at 11 typically. Tomorrow, we're going to be kind of talking about the Heart Month and planning, and it's going to be a little bit more casual, but we meet with different physicians, writers, advocacy partners, patients. Alex joins me for a podcast every quarter or so too. So we have different conversations, and it's a great way to learn. Nothing happens in a silo. We are an amazing team. Last year, 2022, we had almost 3,000 hours of volunteer service to the HCMA, and there's going to be a lot more ways for y'all to get engaged this year. And if you engage as a volunteer, which Julie can help you do, your hours are actually going to go to prizes, and you can even earn admission to the HCMA annual meeting, which is coming back in live time on October 21st, 2023. So if you do enough volunteer hours, you can get a free pass to the meeting and potentially even to the gala. So look on the website for information about those perks. And we thank you all, especially our HCMA Recognized Center of Excellence partners at University of Pennsylvania. My bullet's a little off here. To our staff, to our board, to our volunteers, and to Brandy, who 2 days ago, 6 years ago, I got to go home on Valentine's Day with a brand new heart and a brand new lease on life. So thank you to Brandy and her family for giving me a chance at surviving. And I'm going to hand it now off to Charlene Day, who's going to talk to us about exercise in HCM. And I forgot to load the freaking poll because I was not okay, you're going to get launched a poll now, people. As Dr. Day is talking, if you would be so kind as to answer the poll questions, if you're in the Zoom room, then we can get on to telling everybody like where they came from and what's going on. Charlene, it's up to you now.
Hi, everyone. Lisa, thank you. That's just so inspiring, everything you're doing, just really wonderful initiatives. And it's so great to see what you're able to accomplish and, over the years. And, I've known you for a long time, and, your organization has just grown by leaps and bounds. So
Thank you.
It's wonderful to be here. Thank you all of us for joining. So today I'm going to talk about exercise in HCM. And as Anjali said, this is one of my favorite topics. These are some of the questions that you all ask us. Is it good for me to exercise? Is it safe for me to exercise? How much exercise can or should I do? And what about high intensity exercise or sports participation? And, when I started my HCM clinic over 15 years ago, we didn't have the answers to these questions, and we just didn't have any information to guide recommendations. And so, there was a lot of concern about whether any level of exercise could trigger dangerous heart rhythms. And so as a result, the guidelines were quite restrictive, and there was a lot of uncertainty, and a lot of people were just scared and didn't know what to do. And so, we as providers, engaged with all of you as patients, set out on a mission to try and get more information to inform these recommendations. And so, the first thing we did was to start out with, what's the baseline? What are people with HCM doing now? And so we sent out a survey. Thank you, Lisa, and through the HCMA. The survey was mostly responded to by HCMA participants, as well as patients at the University of Michigan. And what we found was that patients with HCM exercised less than the general population. More patients with HCM were overweight or obese than those in the general US population. And about 2/3 had purposely reduced their exercise after their diagnosis. And for the majority of people, that had a really negative emotional impact on them. And then in another study shown here in this graph from Australia, only about 45% of patients were meeting recommended guidelines of at least 150 minutes of moderate or vigorous activity per week. And so, now we've identified the problem, but we really needed to come up with a solution. So we started with a clinical trial of exercise training. We randomized 136 patients to either their usual activity, whatever they did in their daily life already, or to an exercise training program, which is a structured and home-based program of moderate intensity. And it was an individually prescribed program. And this was an effort between the University of Michigan, where I was at the time, and Stanford. And the program looked like this. Essentially at week 1, we started pretty light, and then progressed over the course of 2 to 4 weeks. And then by week 5 through the end of the study, week 16, we had people maintain their exercise regimen at where they were at. And so here are the results of the study. And for those who like numbers, I'll show you the actual numbers in the top line here. Essentially, what we found is that those people that were in the exercise training group had an improvement in their exercise capacity based on a measure called peak VO2 that increased by 6% on average. And so this is basically a special type of a stress test. Many of you have probably had it, where you wear a mask or a mouthpiece to measure the consumption of oxygen by your heart. And that's shown here graphically on the right, where individual dots are patients, and then the line here in the middle is the average. And patients who were in the exercise training arm also felt better in their daily life, as we recorded their responses on a standardized functional assessment survey. And importantly, we didn't see any major adverse events. There were no arrhythmias. There were really nothing that was concerning that exercise was doing any harm. And so this was very reassuring to us. And this, along with other evidence that had accumulated along the way, led to a change in the guideline recommendations that for most patients with HCM, mild to moderate intensity recreational exercise was beneficial and encouraged. And so, this was a big step forward that was very exciting. And the next question is, how do we prescribe exercise for patients? And I think the important thing is it needs to be individualized. Everybody starts at a different place. Everybody has different limitations based on their HCM or other factors. And we can invoke the guidance of an exercise physiologist to help the patient to individualize their exercise program. We target, in general, 150 to 300 minutes a week of moderate aerobic exercise, but this can vary, of course. And any modality really is fine, as long as people are getting their heart rate up and getting some exercise for a sustained period of time. And then we define moderate intensity exercise in different ways. You can do it by heart rate. You can do it based on kind of a stress test. But I think the most practical one is just rating a perceived exertion. Like we tell patients, well, if you can carry on a conversation with somebody, while you're working out, then that's probably puts you at a moderate level of exercise. So those are the general, that's a general framework for exercise prescriptions for most people that want to engage in heart healthy exercise. So vigorous exercise is, continues to carry some uncertainties, but the guidelines have evolved quite a bit over the years. These are two that I pulled out of the 2020 guideline document that I think are the most important. And the first is that for those who are athletes that have hypertrophic cardiomyopathy, the guidelines now recommend that we do a comprehensive evaluation, of course, but also a shared discussion of potential risks and of benefits of sports participation, and that conversation occurs with an expert provider who understands the uncertainties and potential risks that they can convey to the patient. And then secondly, that in the context of this evaluation and shared discussion, the participation in high intensity activity or moderate to high intensity competitive sports may be considered. And this is a big departure from the previous guidelines that had recommended restriction and disqualification of athletes with HCM from their sport. And we think this is an important step forward. All of this happens in the context of what we call shared decision making, which we do with pretty much every decision that you make about your care and your health. But he applied here, what it entails is a discussion between you and your provider about what's important to you, what, for example, if this is an athlete in organized sport, why are they doing it? What is their motivation? What are their goals? And then from the expert provider conveying where there's levels of uncertainty, what are the potential risks to consider, what are important considerations around the environment that they're training or participating and competing in. And so at that point, the athlete may choose to withdraw from sport, and then that conversation turns to guiding them along transitioning to a recreational exercise program. Or the athlete may choose to continue to participate. And then if they're in an organized sport, such as a high school or collegiate program, then that conversation often goes to the coaching staff, to the athletic directors, and potentially even to the lawyers, depending on how high it goes and how high the school wants to take it, to ensure that everybody's on board and that there is a environment that is conducive to safe participation for this athlete. So, these conversations still really need more data and more information. And so some of you on this call may have even participated in this study, the LIVE HCM study, which is focused on lifestyle and exercise in patients with hypertrophic cardiomyopathy. And so we have completed the study. We enrolled 1,660 patients, many through the HCMA. Lisa, again, thank you for all you've done here in helping to support the study. At baseline, we have a lot of patients who enrolled who are exercising vigorously, and even many who are in competitive sports. The results will be released and presented on March 6th at a national meeting, so stay tuned for that, and hopefully that will help to inform these discussions. I just want to call your attention to a really helpful resource, which is cardiosmart.org. This is literally what you type in, cardiosmart.org/HCM. There is a whole host of information and educational material. And within that, there is an HCM exercise planning worksheet. So if you've not come across this, I really encourage you to go to this website and check it out. It's 8 pages. So this is just the first page. But it tells you, it gives you sort of a guideline as to documenting what your current exercise habits are, what your goals are, and how to work with your care team to tailor your recommendations. This is one sheet out of those 8. It gives you some tips as far as how to build endurance and how to do strengthening exercises and how to set goals. I think it can be really useful. I have yet to have someone come to me with this. So I'm hoping that maybe after tonight that some of you will print this out and bring this to your next visit to work with your provider to set exercise goals. There is even a weekly HCM exercise planner, so you can also use this to track your exercise and your progress. So to answer the questions I posed at the beginning, is it good for me to exercise? Yes, absolutely. Is it safe for me to exercise? I would say the answer is generally yes, but you should discuss with your HCM physician and team because there may be special considerations for you. And how much exercise can or should I do? Again, I think this should be answered on an individual basis and something to discuss with your provider. And what about high intensity exercise or sports participation? Well, I think this can now be considered in the context of shared decision making. And I'll stop there and I'm happy to take questions.
So I may have been remiss in explaining to everybody that there's a Q&A box at the bottom of this Zoom room, and you can open that up and you can type in your questions at any time during tonight's presentation. And at the conclusion of each speaker, we will answer some of the questions. And if we don't have time to get to them all, they'll wait till the end and we'll answer it all at that time. Sorry about the housekeeping message there, Charlene.
No worries. It's fine if you want to just, there aren't any questions right now. So if you want to move on to the next speaker in the interest of time, and I'm happy to take them at the end.
Well, I'm going to, okay, attendee who's raising your hand, you got to ask in the Q&A box. We're not bringing attendees in verbally, so you'll have to use the question and answer box. If you have any problems with that, just Julie or Stacy can text with you and explain how to do it. I'm not going to let you go without asking a question about exercise in HCM. We've been talking about this stuff for feels like ever.
Yeah.
So I think we have evolved, and I don't think that there is any argument within the professional community that exercise in HCM is healthy and that people should be moving. And if they're having a hard time moving, they should be talking to their team about how they can be as active as possible with their heart. So no arguments there. I think where we end up having some conversations, and I had one this week, it's professional and elite level athletics and what is right for that person's HCM heart, balanced with what their wants are, balanced with what we know and what we don't. So that's not a black and white answer, is it? It's shades of gray.
There's still uncertainty, and we're approaching it different ways. The LIVE study doesn't have a large proportion of athletes at that level, although we do have close to 300 competitive athletes at different levels, high school, college, and so forth. And that's being approached through different types of studies, registries and things of that nature, and following some of these folks out. But yes, there is uncertainty. That is a really important thing to convey when you have these conversations with the athlete, with their families, and with their teams.
So I'm going to there's a couple of comments that are coming in now. They didn't know where that Q&A box was. I knew they would find it quickly. I'm going to talk a little bit about a story, a family that I talked to in the past couple of weeks. Family history of HCM. Dad's been diagnosed a long time, kid was gene positive. Now she's converted to phenotype positive, and not insignificantly so. There's some obstruction, there's a pretty thick heart, and it's good old fashioned HCM. She's a competitive athlete, and she would love to be able to stay a competitive athlete. And for this example, we're going to use tennis as an example. So she likes to play singles tennis, but she'd be open to doubles tennis. And she's looking to go to college and potentially on a scholarship. These are like nuanced discussions, right?
Mm-hmm. Very much so.
Can you talk about some of the questions that you might ask an athlete about level of participation and moderating that activity to their heart?
Yeah,
How does that go?
It's up to them, I think, but obviously, I think again, conveying that I don't know whether singles tennis versus doubles tennis really, pretends any different level of risk, or whether not playing tennis at all versus playing singles tennis, whether the risk is any different. And so, those are the types of questions we're trying to answer through the LIVE and other studies. And so I just think it's important to convey that, and the patient has to decide what level of risk they're willing to take and what they're comfortable with. And if they say, sometimes I've had people say, I was a competitive swimmer and diver, but I just feel more comfortable going to diving because I don't like the possibility, of hours and hours of training, and I'm afraid what it could do to my heart. And I say, that's perfectly fine. I'll support you doing whatever you want to do. So,
We have 3 questions and we're going to do them in
Okay.
rapid session.
okay, I'll go fast.
73-year-old woman with an ICD. What are the guidelines for exercise for a 73-year-old with an ICD?
Yeah, I mean, the guidelines aren't any different for you than anybody else. And the presence of a defibrillator doesn't change the recommendations. But work
Okay.
with your doctor, because obviously you want to personalize that.
Are there any risks to Pilates for strength training?
Not that are known. Again, the low intensity type exercise that Pilates is, I think that falls into what the guidelines would say would be generally beneficial and of low risk.
Heart rate monitors. Should patients trust the numbers that are showing up on their heart rate monitors, and which ones are more reliable?
Yeah, that's not, so I think chest strap ones are the most reliable. The wrist ones are not as reliable. So if you really want to follow your heart rate as a gauge of your exercise level and intensity level, then I would get a chest strap monitor.
Okay, we are cruising through here. And as
Yep.
I clear them out, more questions come in. We're going to do 2 or 3 more, and then we're going to move
Okay,
on to the
I'll
next
go fast.
presentation.
Answer quickly.
Okay, so I'll leave that one. Wendy says great presentation, but we know Wendy. Hi, Wendy.
Yeah.
How do you qualify the sudden cardiac arrest risk prior to the start of exercise or sports?
Yep.
Is an echo EKG enough, or should they get an MRI to evaluate fibrosis?
Yeah, good question. We don't do it any differently before exercise than we do for anybody else. And more, I would say currently we use MRIs for risk strat as part of the risk stratification scheme for most people. But it's not different for, an athlete versus non.
Okay. I like this question. It's a little nuanced. This person was told not to suddenly exert themselves. Is this true? Is there types of exercise that you should do for a period to warm up? And should you do a slow down?
Yep, that's all part of the guidance with the exercise prescription. And Lisa, we've talked about this a lot. Long warm up, I think, is a really good idea. Going from 0 to 60 in 5 seconds is probably not, the best. And so I'd encourage people who are doing more high intensity stuff to do a long warm up, get a good aerobic base. And if they're kind of on the sidelines and they're doing a burst sport, to kind of keep themselves moving so that they're not just sort of going from the bench to, running down the basketball court.
If somebody's heading to transplant and they're in end stage HCM, should they still be doing some level of exercise while they're waiting for the transplant?
Absolutely. Yep. As much as they can do. They're going to be more limited, but as much as they can do to keep moving. Yep.
Yeah. Okay. So I'm going to pause the questions there and invite Alex DeFeria. Are we going with the full name tonight, Alex? Or are we Alejandro? Alejandro's not.
Alex is fine. I'll keep it easy for everybody.
Okay. And we are now going to talk about atrial fibrillation management. Those with questions still pending, we will get to them at the end of this session. We may answer some of them in written form. Okay, Alex, you are ready to go.
All right. You see my screen fine?
We've got you.
Awesome. Well, hey, everyone. I'm Alex. I've known Lisa for a long time. And I'm happy to talk to you guys today about AFib, or atrial fibrillation and HCM. And so if any of you have seen me in clinic, you know that I like to draw a lot of very bad pictures of the heart. So I figured I would start this talk by showing the heart, showing what the HCM hearts look like and what atrial fibrillation is. So here on the top right, you'll see the picture of the heart with the bottom 2 chambers are the ventricles and the top chambers are the atria. And these are different pictures of what HCM can look like. So the thickening can affect different portions, but pretty universally in HCM, patients tend to have thick, stiff hearts with smaller cavities to fill with blood. And so that increases the pressure on the left side of the heart. In combination of increased pressure and difficulty of blood getting out of the left side of the heart, which is obstruction, and sometimes involvement of the valve, which separates the bottom from the top of the heart, can cause blood to go backwards, and that's called mitral regurgitation. And so all of those things combined can cause pressure to build in the top chambers of the heart, particularly the atrium, and dilate those. And when those top chambers are dilated, that puts you at risk for something called atrial fibrillation. And so atrial fibrillation, or AF or AFib, which you probably see commercials about it, is when you have the top chambers, instead of having a nice coordinated contraction where the top chamber squeezes and then the bottom chamber squeezes, the top chambers kind of having a very erratic, abnormal beat to them. And so sometimes people can say that they felt fine, and then all of a sudden they felt extremely fatigued and short of breath, or lightheaded, or felt a sensation of skip beats or palpitations. And I think of palpitations as just being an uncomfortable awareness of one's own heartbeat. And sometimes patients can say they have chest pain. And in those instances, patients will say, I felt immediately at this time, I just felt off, and I've felt off since then. And a lot of times in those instances, that can be AFib or atrial fibrillation. The other thing is that sometimes patients can have no idea they have AFib, and they can be completely asymptomatic. And that is why we screen for AFib yearly. And so sometimes the AFib can be brief, and it can be what we call paroxysmal AFib. Sometimes it can be persistent and last long periods of time. And sometimes we call it permanent when it's persistent and it's resistant to things we do to try and get people out of AFib, like using electricity to try and resynchronize the heart or a cardioversion. And so AFib is pretty common. In the United States, if you look at all comers, it's about 3 to 6 million people have atrial fibrillation. And by the year 2050, it's projected to reach up to 16 million. And if you stratify by age, above 60, about 4% of patients will have AFib, and above 80, it gets up to 9%. And so looking at the general population numbers then makes the population HCM even be more staggering. Because if you took, in a recent study, all patients with HCM evaluated at referral centers, anywhere between 18 to 28% of patients with HCM at some point have had AFib. And that's up to 4 to 6-fold more than the general population. And so things that increase the likelihood of developing AFib, it's seen more in older patients with HCM. In patients that are diagnosed young, so less than 40, over the course of their lifetime have a higher risk of developing AFib. And then anything that leads to increased left atrial size. So obstruction of blood flow coming out the heart, regurgitation of blood into that top chamber, and increased pressures that lead to left atrial enlargement can then cause those top chambers to go into atrial fibrillation. And so how do we detect AFib? So in our practice, we tend to do 2-week monitors. The guidelines, I think, say 24 to 48 hours yearly is enough. We usually do 2-week monitors, though, just because we like the longer detection time. And we do those yearly in our patients. And detection of those rhythms can be both abnormal rhythms from the top chambers, so atrial fibrillation, atrial flutter, which is similar to atrial fibrillation, or just skip beats from the top chambers of the hearts. But these monitors also look for bottom chamber rhythms, like non-sustained ventricular rhythms, like ventricular tachycardia. They're the ones we get really concerned about for increasing your risk for sudden death. So we do those yearly. If you have a device, if you have a defibrillator, especially the dual chamber defibrillator, where we have the wire in the top chamber, the atria, and a wire in the bottom, they're very good for detecting abnormal rhythms. And we will remote interrogate those, or when patients come in and get their devices interrogated or looked at, we can see those rhythms. And even the single chamber devices can detect AFib, just not quite as well as if you had another wire detecting in the top chamber. And then more frequently, I get this all the time now, that with the wearable devices, like what Dr. Day was talking about earlier, some of these devices like iWatch, Fitbit, can detect abnormal rhythms pretty well. And so I've had multiple patients say, my watch detected and said that I had AFib and I was feeling poorly. And then sure enough, they come in, they send me the strips, and they come in and see me, and they're in AFib on the EKG. So a lot of different ways of detecting AFib. And so why does atrial fibrillation matter? Well, there's a high risk of stroke with atrial fibrillation. And so at the top right, you can see another picture of the heart. And one of the reasons that you have a high risk for stroke is because there's this little part in the top chamber where blood can pool. And when you're in AFib, the top chambers aren't squeezing, so blood just sits there and can form clots. And so that puts you at risk for strokes. And in all comers, about 5 to 10% AFib, depending on the risk factors, but with high risk, if you aren't on anticoagulation, you can have a pretty high percent risk of stroke. And that's the same whether you're in AFib paroxysmally or in and out of AFib versus if you stay in AFib. But some studies have suggested in HCM, the stroke risk is much higher. It can be up to 27% in patients that aren't anticoagulated. And so that's something that we tend to see. Unfortunately, a lot of our HCM patients are young and have no other risk factors other than having HCM when they pop into AFib. And even in other experienced clinics, sometimes they aren't on anticoagulation. And so it's important that if you do have HCM with atrial fibrillation, your stroke risk is high regardless of what your other risk factors are, and that anticoagulation should be considered. The other important thing about AFib and HCM is that it can have a significant impact on your quality of life. Most of my patients that go into AFib do not like it. Partially is because the heart is stiff and thick, and you need as much help as you can filling the left side of the heart up with blood so you can push that blood forward and do all the things you want to do. As soon as you go into AFib, the top chambers aren't contributing to the blood flow anymore. They just sit there and quiver. And so as soon as people go into AFib, they say, I feel terrible. And that's regardless of whether they have obstruction or not. A lot of patients really just do not tolerate atrial fibrillation. And so what's the management? So medical management is focused on either controlling the rate and slowing the heart rate down, because atrial fibrillation can either be really fast or slow. And another side of management is actually controlling the rhythm and trying to get you out of atrial fibrillation with medications. And so you'll see medications called antiarrhythmics. Those are the ones that get you out of the atrial fibrillation rhythm. And examples of those are things like dofetilide. Another name for that is Ticasin. Amiodarone is also very good at getting you out of AFib. Downsides of amiodarone is it can have long-term side effects on different parts of the body. So I usually tend to not have patients stay on amiodarone for very, very long periods of time if we can avoid it. And then sotalol is another good option. And then disopyramide or Norpace, which is one that we use to treat obstruction and symptoms, can also be used for atrial fibrillation, but usually that is in combination with one of the medicines that helps slow the heart rate down. Those would be the AV nodal blockers like metoprolol and verapamil, which we commonly use to treat symptoms in HCM. If medications don't work, or if patients don't want to take an extra medicine, there are other more invasive options to treat atrial fibrillation. One of them being ablation, and in this instance, it's not the septal ablation that you might hear about for obstruction of blood flow, but these are ablations for the atria, where they take tubes or catheters and they go into the top chambers of the heart, and then they try and break those abnormal electrical signals that cause AFib. And so ablation's an experienced electrophysiology center. So this is what the electricians, the electrophysiologists do. Those ablations can be very successful, even though in patients with HCM, there tends to be a higher rate of recurrence of AFib than in all comers. So at times you may need a second procedure. And there also may be a higher rate that you might need to also need a medicine after the ablation. But ablation can be, in the right center, can be a very good option to get you out of atrial fibrillation. Also, if you're going to surgery for a myectomy, at the time of surgery, you can do a surgical ablation. And you can also, that little part of the left atrium that sits there and can build clots, called the appendage, we can ligate that or seal that off to decrease the risk of having blood clots form there. And then lastly, left atrial appendage devices like Watchman and things like that can be used. There's not a lot of great data in HCM alone to use that and not anticoagulate. So we don't tend to do that very often. But there are multiple options to treat atrial fibrillation. And then just the other part of the management is the really important part about preventing stroke. And so, like I said, HCM patients with atrial fibrillation, regardless of their traditional risk factors, should be considered for anticoagulation. And you'll hear different options. A lot of commercials you'll see for Eliquis and apixaban, Xarelto, the newer blood thinners that don't need monitoring. And then also warfarin, if you can't be on one of the other medicines, can be a good option. You just have to have monitoring for that medicine. And so in summary, atrial fibrillation is common in HCM. Up to 1 in 5 patients with HCM will experience AFib at some point. It can lead to debilitating symptoms that we discussed earlier. But some people have no symptoms, and that's why we screen for this. It can significantly increase your risk of having strokes, and so that's why it's important to be talked about blood thinners. And then most patients will feel better in a normal rhythm. And so if you're an AFib that has been refractory to maybe some of the standard medicines, some of the more escalated therapies should be considered. And that's my little monkey, Flora.
That's a cute little monkey.
Yeah.
That's a very cute little monkey. Thank you. Okay, so now y'all find that Q&A box and fill it up with AFib questions, and I'll start. So percentage-wise, about 25% of HCM patients will have AFib at some point or another. And I want to just talk about how common it is and how it can often go the other way. First, somebody's diagnosed with AFib, and then we figure out they have HCM. Why is HCM AFib different than non-HCM AFib?
Yeah, the whole idea of being diagnosed because of AFib, especially, so Penn is a very robust EP electrophysiology program. And we have diagnosed so many patients when they come in for their atrial fibrillation ablation and get an MRI, and that's the first time they're diagnosed with atrial fibrillation or with HCM. And so it's not uncommon for that to be your presentation as AFib. And unfortunately, especially, I've noticed this with apical HCM, where maybe the echo doesn't catch the apex and you're measuring the walls at the top of the heart and no one uses contrast. You just never see for years and years. You get echoes and all these things, and oh, your EKG is abnormal and you don't feel great, but I'm not sure why. Maybe it's just the AFib. And then sure enough, once they get the MRI, that happens, and that's how they're diagnosed. So that is very common, and we see that all the time. And just when you have and they call it diastolic dysfunction, which is the stiff heart that comes with HCM, most patients do not tolerate AFib at all. It just really wipes you out. And very few have told me, no, I didn't feel it at all. But the vast majority say, I just feel wiped out. And even I had a patient recently that had a myectomy and had no obstruction and felt great for weeks. And then one day said, I started feeling terrible at 7 a.m. yesterday. And I was like, okay, I'm concerned you're an AFib. And sure enough, atrial fibrillation. And so and the HCM heart, because of the importance of having the top chamber contribute to the overall flow of blood, when they lose that, a lot of people just don't like it.
Okay, we have some questions. So I will give you fair warning, Shirley, and one of these is a combination question. So you might want to come back and hang with us.
I'm still here. I'm typing answers to the questions that we didn't get to.
I saw that you were typing. I'm like, I know you're still here, but you might want to come back on because this one question is a combo.
Okay, I'll wait.
Does atrial fibrillation affect the safety of exercise?
That's a good question. I would think that, well, first of all, it might make it harder for you to exercise and tolerate the exercise. And some patients that have atrial fibrillation, when they try and exert themselves, kind of the sympathetic drive of exercising will cause their atrial fibrillation to go way out of control. And so I would say that I would imagine that being in a normal rhythm would allow you to exercise more efficiently and feel better. So that's how I would approach that question as opposed to the safety of it. I mean, I would imagine that though your rates would be it's very erratic. If anybody in this group has ever had AFib, you'll see your heart rate be 150 1 second and then 70 the next. And so I would imagine being in a normal rhythm would allow you to exercise more and safer.
Charlene, you want to comment? Just a thumbs up.
I don't have anything to add. I mean, I think if you're in rate controlled AFib, like permanent AFib, you know, I think you should be able to exercise fine.
Okay. If on Eliquis and have daily AFib, is there still a fair risk of stroke? Can you develop clot on an anticoagulant?
So there is good data to show that being on an anticoagulant and consistently, so Eliquis is twice a day, will decrease your risk for stroke significantly. To say the instances that I've seen patients have strokes while on anticoagulants, unfortunately, sometimes it's missed a dose or for whatever reason, they couldn't get the drug, but usually it decreases your risk significantly. There are some particular instances that are not related to HCM, like certain clotting disorders that can be separate, that respond better to other types of blood thinners, but not necessarily HCM related. So we feel very confident when we prescribe some of the newer anticoagulants like Eliquis that it will decrease your risk for stroke.
Okay. I do know of a few anecdotal stories, and we all know them, that you can still develop some clot on an anticoagulant.
Yeah, so there are in a disease that looks similar to HCM sometimes, amyloidosis, where the top chambers get really, really big and don't move at all. Those patients I've seen have clots through the traditional anticoagulants. Usually, if someone has a clot while on one of those, like Eliquis or rivaroxaban, we a lot of times will consider switching to the other or switch to warfarin. The problem with warfarin is that you have the INR checks, and our lives are already tough. So then to add on frequent lab draws, even though with long-term you can get good ranges of INRs on Coumadin, usually our go-to though has been Eliquis or rivaroxaban. But if there is a clot, we will switch anticoagulant. There are a couple of instances, but it's not common.
It's not common. Okay. So this is, I kind of know the answer to this one, but I'm going to let you answer this one. If you have AFib post-op from a myectomy, is that an indication that you're going to have AFib later in life?
I've seen this twice in the last month. And so I think that across the board, patients that don't have HCM, that go for open heart surgery, there is an increased risk for atrial fibrillation because you are literally tinkering with the heart. And anything that irritates the heart will put you at increased risk for atrial fibrillation. So HCM is different because most patients that are coming for surgery for HCM are coming for a myectomy. And that means they've had years of obstruction and probably years of increased pressure and even likely blood going backwards into the top chamber. And those atria are big. So they're already a setup to go into atrial fibrillation going into the surgery. And so I would imagine your risk is higher than someone that has a normal sized atrium going into the surgery. And so, my practice thus far has been, even if it's AFib around the time of surgery and we get you out of it, I've been keeping patients on anticoagulation after surgery and then doing long-term, some form of monitoring to see. And then it's an individualized discussion. It's complicated long-term about if it's just very brief around the time of surgery. But I've been keeping patients on anticoagulation as long as they can tolerate it, because usually you have a large atria and there's a good chance you're going to develop this at some point.
So definitely maybe and maybe not.
There's the other percentage, the large group that never develop AFib. There's also the large percentage of patients that have severe obstruction, don't have symptoms. I don't understand that either.
No.
We are
rare
I think
birds.
AFib is increased risk, and it's an increased stroke risk. So we take it very seriously.
Okay, because we ask questions here in a way that kind of homogenizes some of the comments here, I'm going to homogenize one. So there's a number of different medications that can be used to treat atrial fibrillation. Some of them are a little less common, like Ticacin. So if somebody has failed Ticacin, is there a role for flecainide or some of the other old school drugs?
Yeah, some based on very old data from trials, like a trial called the CAST trial, has talked about certain antiarrhythmics like flecainide and other ones and structural heart disease can be sometimes a little bit challenging. So we tend to use at Penn, a lot of our interventionalists like to go towards Tecousin first, because it's a pretty straight and safe drug. There can be some issues with the QTC, which is why we monitor, and QTC is part of the EKG rhythm we look for when we're starting patients on these drugs that we monitor. But overall, it tends to be a decently tolerated drug, and so that's why we go for Tecousin first. I would say that the practice here has been, if they fail Tecousin, and anybody else in the group can jump in if they've had a different experience, but if they fail Tecousin still in atrial fibrillation, a lot of times we start talking about, is it time to try an ablation? You know, I know I mentioned amiodarone. Amiodarone is a really good drug. It has a lot of issues outside of the heart that you have to monitor for, and especially for young patients, I tend to not use that drug for very long. And even for older patients, I mean, you know, being on amiodarone for a very long time can cause some issues with the liver, thyroid, with vision. So we're a Tecousin heavy program. Other programs might have different approaches though.
Okay, we're going to move on and we're going to leave the questions. That the faculty is more than welcome to go to the Q&A box and type answers as well as we go along. You've got a very inquisitive group here tonight. There's a lot of questions. Sometimes we don't get a lot, but they're all fired up tonight for you guys. So we're going to bring on our next presentation, and let me make sure I have the order correct. I believe we're speaking of advanced heart failure and transplant. Yes, we are. And we have, I don't know you. This is a new one for me. Nosheen, is it Reza? Am I pronouncing that properly?
Riza. Thank
Riza.
you.
Okay. Lisa will introduce Riza.
All right. Hi, everyone. It's great to be with you this evening. I know we're running short on time, so I actually don't have a ton of slides. I've designed this to be a conversation and mostly to introduce the concept of heart failure and transplantation in HCM. But I know we've been a super engaged group so far, so I hope this continues. So let me just go ahead and start and say, well, let's just start by defining what heart failure is. And in simple terms, it's a problem with how your heart pumps. Now, you all have probably heard the two major concepts behind describing heart failure. Those include heart failure with reduced ejection fraction, where the heart cannot pump or squeeze enough blood out to the body. You can see in the cartoon that these chambers become weak, the heart muscle becomes weak over time. And then there's the concept of heart failure with preserved ejection fraction, where the heart can't fill with enough blood to pump out enough blood with every heartbeat. You can see the cartoon is showing that this is a situation where the chambers of the heart become stiff and fill with less blood than usual. Dr. Alex DeFeria just sort of talked about this, so I'm not going to belabor this point. But in sort of garden variety, quote unquote, heart failure, these are our two major distinctions. Now, what is advanced heart failure? So symptoms generally of heart failure include those that I'm showing here: extreme tiredness or weakness or fatigue, feeling lightheaded, rapid changes in weight, meaning specifically rapid weight gain in the setting of fluid retention, the sensation of swelling in the ankles, legs, abdomen, a rapid or irregular heartbeat, which we just heard all about, sensations of shortness of breath, trouble breathing when lying down or waking up at night short of breath. And then, so that's all symptoms of heart failure. And I hope, you know, the folks who take care of you have sort of talked you through all these symptoms. And the challenging thing with HCM is that some of these symptoms occur when you're not in heart failure, when that's not part of your medical history. But what makes it advanced heart failure? I would say that it's the presence of these symptoms that are occurring despite maximal medical therapy for whatever type of HCM is in occurrence, whether that's non-obstructive HCM or HCM with obstruction. And advanced heart failure is really what we're talking about when symptoms are occurring at rest. So meaning you're not doing anything, no activity, but you're having the symptoms shown here. Advanced heart failure also includes frequent hospitalizations for these symptoms, cardiac related hospitalizations, and the need for specialized interventions like IV medications, intravenous medications that you can't get in pill form, needing to be hospitalized for specific hospital only management strategies. So that's really the concept of what takes heart failure to being advanced heart failure. Now, what is heart failure in hypertrophic cardiomyopathy? And so I think just sticking with the sort of distinction that we traditionally use in HCM, the non-obstructive versus obstructive kind of presentations. So heart failure in HCM develops, when you've heard a little bit about this already, these symptoms that are related to difficulty with the heart being able to pump blood and the inability for the heart to pump out enough blood to meet the demands of the body. Now, on the contrary, with obstructive HCM, it's very rare to transition directly to heart failure from an obstructive state. Typically, and sort of jumping ahead a little bit to folks who are interested in the concept of transplantation, directly jumping from obstructive HCM to heart transplant is not something we do because there are therapies that we know that can treat and reduce the amount of obstruction and therefore improve symptoms. And so that jump is not necessarily one that we see very often, or if at all. You certainly can transition to a state of having heart failure if you have started out with having obstructive hypertrophic cardiomyopathy when the obstruction is long-standing or untreated, and the heart muscle adapts negatively over time to those conditions. So one thing I want to leave you with is thinking about this concept of ejection fraction. Ejection fraction is a measure of how much blood is pumping out of your heart with every heartbeat. And our current disease guidelines tell us that when the left ventricular ejection fraction, LVEF, drops to less than 50% in hypertrophic cardiomyopathy, that's when we should be concerned about the development of heart failure in this disease. Now, that's not to say that's an absolute. People can have heart failure symptoms, even in the situation where the ejection fraction is above 50%. But really, this is meant to tell us, those who take care of patients with HCM, to really be alert if we see these progressive decline in ejection fraction with HCM. So I just want to also call your attention to, because the concepts of heart failure and ejection fraction you may hear a lot about, because of course there are non-HCM causes of heart failure. In those non-HCM conditions, the left ventricular ejection fraction, LVEF, typically is marked at 40% or less, designating a state of heart failure with reduced ejection fraction. So this is a true distinction. And again, for folks that are skilled in taking care of patients with HCM, it's important to know that the distinctions with ejection fraction to when we were concerned about development of heart failure is different for patients with HCM versus without HCM. So then just taking you through this kind of transition to advanced heart failure in HCM, we know from studies and registries that you've heard a lot about already that advanced heart failure is rare in HCM. It happens in, from what we know, about 3 to 8% of individuals overall with HCM. But with the amazing advances in treatment we have for a lot of other things like sudden cardiac death, atrial fibrillation that you've heard about, we're learning more and more about the burden of advanced heart failure symptoms in our patients. And so let me just take you through this little roadmap diagram of what we're thinking about when we see patients who are developing declines in their ejection fraction, perhaps reaching that threshold of 50% of a left ventricular ejection fraction. So of course, what we first do when we individualize and sort of see patients with that decline in ejection fraction, number one, we have to rule out other causes of heart failure. So you're a patient not only with HCM, but perhaps you have other risk factors for cardiac disease. It's our job to make sure that we've evaluated anything else that could be contributing to your low heart pumping function. So we do that, absolutely. Number two, we'll assess your risk factors for progression of your ejection fraction declining more or further declines in your heart pumping function. You've heard about some of these risk factors already, but just to lay them out in particular, we know that patients who have atrial fibrillation, that elevates the risk for down the line developing decreases in your heart pumping function. If you're already starting out with ejection fraction of 35% or less, that is a sign that you're going to likely be, well, you'll be more likely to progress to needing other advanced therapies. We know that genetics is playing a role. Some of our studies have shown that in individuals who have genetic changes in multiple areas that impact the sarcomere, or the muscle unit of the heart muscle cell, those people are more prone to having heart pumping problems. We've talked about ventricular arrhythmias as well. We've talked about heart muscle scar in the context of exercise, but we of course pay attention to the burden of heart muscle scar when thinking about heart pumping function as well. And then of course your symptom burden. How limited are you, and do you have those symptoms at rest that I was mentioning earlier? So if you're somebody that's transitioned to this state of a left ventricular ejection fraction of less than 50%, we often you'll see us switching your medical therapy to a philosophy that's called guideline directed medical therapy. So that's borrowed from the non-HCM heart failure literature. These are medications that again have been studied in non-HCM patients that have been shown to prolong and save lives. In those individuals, there are no trials or should say randomized trials of heart failure therapy for patients with HCM and heart failure. So we're extrapolating that data to our HCM patients. So if somebody's in this state, we'll start to change the medicines at this point to try to more align with what we know has helped other patients who have heart failure. For patients that have heart failure symptoms, we may refer you for what's called cardiopulmonary exercise testing. We've talked about that in the context of exercise, but this is in particular to help us understand your cardiac performance. We may also ask you to get a right heart catheterization, which is a procedure that helps us measure the pressures inside the heart and also a direct measure of the cardiac performance as well. This is helpful for us for really establishing what your baseline function is at the time we're seeing you, what is happening in your heart when you're having symptoms, and to help us make a prognosis for you. Other things I'll put here that you may come across, of course, we've talked about the implantable cardioverter defibrillator or ICD and the indications for that. If you're not somebody that already has an ICD, for another reason, when your ejection fraction drops to less than 50%, this may become a topic of conversation, again, for the same goal of protection from sudden cardiac death. And if you have something on your EKG pattern called a left bundle branch block, you may be eligible for something called cardiac resynchronization therapy, or CRT for short. What that really does is help both ventricles of the heart, the right and the left ventricle, beat together in a more synchronous fashion. Again, the data for this is really extrapolated from non-HCM heart failure patients. There's not super strong evidence for this in HCM, but it is something that we do in select patients if we think it will benefit them. And then, of course, if you're somebody that has persistent advanced heart failure symptoms that we've talked about, refractory or recurrent arrhythmias that are hard to control, especially ventricular arrhythmias, we're, of course, then thinking about referral for heart transplantation. I have an asterisk here on the slide that you'll see that says LVAD is possible. There has certainly been a lot of different literature out there, and I think there are some perceptions that an LVAD or left ventricular assist device, a mechanical pump that takes over the pumping function of the heart, is not an option available to HCM patients, but that's actually not 100% true. There have been case reports from other series of reports of patients getting this therapy successfully at institutions. Of course, picking the patient who will benefit most from this procedure is important, but it's not an absolute therapy that is not indicated in HCM. It could be indicated in the right patient. So I just want to close by saying, at the University of Pennsylvania, we actually last week celebrated 57 years of our transplant program. We've done over 13,500 organ transplants. We've done over 1,500 heart transplants, and Penn Medicine is the largest heart transplant program in the region. I think one of the things that makes our program really unique is that our founding director, you already heard from her, Dr. Anjali Owens, is a heart failure transplant cardiologist, and there are multiple other folks in the program like myself. I'm advanced heart failure transplant trained. Dr. Ken Margulies is also trained in advanced heart failure and transplant. One of our other partners who's not speaking tonight, Dr. Teresa Wang, is also trained in advanced heart failure and transplant. So we approach the concept of heart muscle disease from that lens, from people that are trained in heart muscle disease and trained in understanding the spectrum of heart muscle disease as it progresses from asymptomatic stages to end stages. So with that, I'll close, and I'm happy to take questions or move on.
Sorry, a pop-up popped up while I was trying to unmute myself. So great talk, near and dear to my heart, both of them. Transplant humor, it's a thing. So a couple of questions that have popped up. Are diastolic dysfunction and preserved ejection fraction heart failure the same thing?
Great question. I would say in 2023, they're not exactly the same thing. We should not use them in synonymous fashion anymore. The diastolic dysfunction is a component of what makes up what we define as preserved heart failure with preserved ejection fraction. But that's a great question.
So here's an interesting question that's actually got potentially a future answer in wearable technology, but not right now, I don't believe. How is the left ventricular ejection fraction tested, and can it be done at home by a patient?
Yeah, that's so great and timely. So traditionally, of course, we test left ventricular ejection fraction with a tool called echocardiogram, typically something that's called a transthoracic echocardiogram. That is an echo done on the surface of the chest, and it's an ultrasound technology, so there's no radiation, nothing like that. And in HCM, our disease guidelines tell us that we should be doing annual testing with echocardiograms every year, annual surveillance for our patients. And one of the reasons for that is to watch this left ventricular ejection fraction. Another way we can evaluate the left ventricular ejection fraction is through a cardiac MRI, which is a different type of test, but also gives us very good information about, again, this ejection fraction number that we're interested in. And to your last question, can it be done at home by the patient? Not exactly yet, but just recently, in the last month or two, we've actually seen some really interesting reports from folks that are really trying out novel technologies to be actually, that can actually take echocardiographic technology to the patient at home. So stay tuned. I do hope one day in my career that I will be able to answer this question and say, yes, it can be done at home by the patient. We're not quite there yet, but we're working on it.
Okay, so let's talk a little bit about that right heart cath that needs to be done to evaluate for transplant. There are three really critical numbers that patients are often perplexed by when they're potentially facing transplant. And they are cardiac output, cardiac index, and the normal values from a CPAT. So can you talk about where numbers are? Because HCM patients don't have normal numbers in all of these factions. But where do we start to be concerned, and where do people get that deeper conversation from the transplant program? Where do the numbers have to hit?
Sure. So I think you could ask a bunch of different HCM cardiologists this question. You probably will get different answers. I'm going to answer it from the lens of a heart failure cardiologist who was trained by a heart failure cardiologist who also knows HCM very well. So I'll start with the non-invasive test first, the cardiopulmonary exercise test. So in non-HCM heart failure, what our studies have shown us is that for patients who achieve this number, you may have heard of it, I'm going to say it out loud. It's called a peak oxygen consumption, or a peak VO2. That's the kind of primary value that you'll hear people talking about mostly from the cardiopulmonary exercise test. If that number is 14 or below, and again, non-HCM heart failure, that triggers a conversation about evaluation for heart transplant in patients who are on beta blockers. For reasons I won't get into, that number can be different, as low as 12. And again, non-HCM heart failure. In HCM related heart failure, those values are not exactly the same. We do know that patients can experience advanced symptoms, signs of advanced heart failure, even when their peak VO2 is above that threshold of 14. And so we like to use, in our practice, I'll speak for ourselves, we actually use CPET a lot. And that's because we like to keep an eye on the annual trajectory of a patient. If heart failure or heart pump dysfunction is something we're concerned about. To us, it's not just a matter of what the values are discretely at any one period of time. It's a lot about the trajectory of the patient in combination with the other things they have going on. Number two, about the right heart cath question. Again, I'm kind of loath to throw out numbers because, again, I think just suffice it to say the theme is that the numbers that we look for in, or sort of pay most attention to in a non-HCM heart failure patient, are going to be different than the numbers we pay attention to in an HCM heart failure patient. And again, coming at this from a heart failure transplant cardiologist lens, we actually care about all the numbers. So yes, I care about cardiac output and cardiac index, but I actually care about every single piece of data that I get from the right heart cath.
Okay, so I'm just getting text messages about all kinds of other stuff here. Okay, so I will say, as a person who has transplanted and somebody who thought she understood things better than maybe she did at the point in time, I delayed my right heart cath because I was not willing to accept the fact that I was heading to a transplant, even though I was heading to a transplant. So I would encourage patients when that EF starts to drop, don't wait too long to get that first right heart cath if it's suggested that the T word is in the future, as I used to call it. Because my first heart cath was when it was almost too late. So when you go off the edge with HCM, it can be a little scary. It's better to do these things in advance, plan, get your plan in order so you can deploy it in time without it becoming really, really dramatic. It's dramatic enough getting a heart transplant, and I've been there, I've done that, but don't push the envelope. Keep in touch with your doctors, get those tests regularly, and move
And
forward.
I can't help but unmute myself, Lisa, and say, even before your ejection fraction drops, if you're having those symptoms of advanced heart failure, you're having more refractory atrial fibrillation, you're starting to need a diuretic, that's really the time where we would say, come in and let's check the numbers. So even before the ejection fraction drops.
Okay. One last question here, because I know what she's talking about. We spoke recently. Is it possible for a pacemaker to induce somebody into failure when they have HCM and maybe they've had a dual chamber pacer for a while? Is that a driver of a pacemaker induced cardiomyopathy on top of HCM? Or is that more likely HCM natural history?
I think I'm going to try to answer your question if I understood it. So yeah, great. I say great question, because pacemaker induced cardiomyopathy is of course a thing. It's something we have to worry about. And typically, it does take a significant amount of sort of single ventricle RV, right ventricular only pacing to cause a pacemaker induced cardiomyopathy. And that comes from sort of what I was alluded to earlier, the sort of lack of synchronous heart beating between the right ventricle and the left ventricle. The heart just doesn't like to beat like that. And so there are specific times when perhaps we may use RV pacing strategy to treat HCM. One of those indications, for example, is a significant obstruction, and that's so obstructive HCM. Other past studies have shown that specifically doing what's called forced RV pacing can help reduce that gradient. I would say it's done less often now because we do have medications and other interventional therapies that are more effective at treating obstruction. So it's very not so common that we'll see somebody that needs RV pacing so much or has had so much RV pacing that they're now developing a cardiomyopathy in that context. I think part and parcel of your device care is to know those percentages. Those are some things that your electrophysiologist will check every time you get your device checked. What is, no matter how many leads you have in, no matter where they are, how much are they being used? And I think it's totally within your realm of right to know.
Absolutely. I'm going to share the study result or the poll results, and then we're going to move on to our next talk in just a moment. So on your screen now, you're going to see that we have representation from 3 countries tonight. We have a lot of Northeast, some Southeast, some Midwest US, and some West Coast. We've got Canadians and Australians with us tonight. So welcome to those. Of those who are here with us, 68% are patients, 17% are patients with a family member also diagnosed, 13% are family members. We've got some medical providers here tonight as well. 17% were diagnosed in the last 2 years, so they're in that shock phase still. 79% are on medication, 43% have an ICD, 32% have had septal reduction therapy. 47% have atrial fibrillation, so it's a high AFib population tonight. 23% of us have lost a family member to HCM. There are 3 other transplants here, so there are 4 transplants in the room tonight. So statistically, we're abnormal tonight. 60% of you have had genetic testing. Bravo! That takes us to our next talk in a minute. 2% have been recommended to have an ICD, but have not done so yet. And 6% have been recommended to septal reduction therapy and have not done it. And 30% are considering a new medication or therapy at this time. So we've got some decision makers in here tonight trying to figure out their next move with HCM. So we're going to move on to our next talk, which is Jessica, who's going to talk to us about genetic testing. And Jessica, the floor is yours if you want to do a screen share and unmute yourself.
All
Now,
right.
there you are. There you go. Thank
All
you.
right. Okay. So it's very nice to talk with all of you tonight. I'll be chatting some about genetic testing and results interpretation for HCM. We're going to focus on kind of some updates in the field of genetics as it relates to HCM, go over possible results from genetic testing, and when to consider doing another genetic test if you've already had one before. Classically, we've always kind of thought about HCM as being what we call a monogenic or a Mendelian genetic condition. This means that there's typically just one really rare genetic variant or mutation in one gene that's causing HCM to develop. And people with this form of HCM, they're typically diagnosed at earlier ages and may have a family history of HCM or sudden cardiac death as well. Genetic testing, this is what we've been doing genetic testing for in HCM for over 20 years now, but we certainly don't know all of the genes that cause monogenic or Mendelian HCM at this point, as there are still quite a few families that we see where HCM runs in their family, but we can't find that genetic cause for why it's happening. Kind of more recently, we've begun to appreciate that there may be some people with a different form of genetic HCM called polygenic HCM. This is a form of HCM that's caused by multiple really common genetic variation or variants that in of themselves aren't enough to cause HCM, but when you add them all together and add in lifestyle, age, and other risk factors, can cause HCM in that person. This is maybe something that you think about, at least there's other polygenic traits or conditions that are far easier to think about than HCM in some ways. So like eye color, height, type 2 diabetes, and most forms of high cholesterol are really thought to be these kind of polygenic traits or conditions. People who have a polygenic form of HCM often have much more mild disease, are diagnosed later in life, may typically have no family history of HCM, and have negative genetic testing for those monogenic causes. There's really no genetic testing available for polygenic HCM specifically at this point in time. And it's still quite challenging, I think, for most people to be able to tell the difference between someone who has monogenic HCM with negative genetic test results due to, say, a mutation or a variant in a gene not yet discovered versus who has polygenic HCM. But this is certainly something that's a little more newer of a concept for HCM genetics. So focusing more on, for the rest of this talk, on monogenic or Mendelian HCM and genetic testing for it. The process, we certainly offer genetic testing to virtually everyone who has HCM, and a lot of you here have, as we just heard, have had it. The purpose of genetic testing at this point in time is mostly for family members. And there's at least currently, although this is probably going to change in the near future, as Dr. Owens will talk about next, the genetic test results very rarely impact the care of the person who actually has HCM. Genetic testing can be done on a saliva sample, on a cheek swab sample, or even blood. So it doesn't have to be blood if people are particularly squeamish. And the cost of it is typically covered by most insurances. I know that a lot of people have heard that genetic testing is pretty cost prohibitive, but that's really not the case for most people now. And most of the patients that we see pay no more than $200 for their genetic testing. There's a lot of different labs that do genetic testing for monogenic or Mendelian HCM. These are a few that we've used over the years. There are some that are certainly better than others, but these three tend to be pretty good. Thinking about genetic testing and making sure that we're all on the same page in terms of what exactly genetic testing is and what it's looking for. Our DNA, our genes, they're made up of letters. And just like with our words in our alphabet, it matters how those words are spelled out or those genes are spelled out. And so the genetic testing is looking for spelling changes in our DNA code that make those genes that can cause HCM not work anymore. And that's what predisposes people to HCM, is when one of these genes isn't working because it has one of these mutations in it. Now, not all variation, not all spelling changes that we find are actually harmful. And that can really make interpreting genetic test results a little bit tricky. And so we're going to get into a little bit next about, possible test results from genetic testing, kind of the trickiness of it. But generally speaking, there are really 3 possible test results to get back from genetic testing for HCM. You can have positive test results where we found what we call a pathogenic variant or a mutation that explains why someone got their HCM, and family members can be tested for it. There can be completely negative results, and where we only find benign or harmless genetic variation. And genetic testing isn't going to be super helpful for family in that scenario. And then there's the possibility for inconclusive genetic test results as well. And we're going to talk about that a lot next. So inconclusive genetic test results are what we call variants of uncertain significance, or VUS. By definition, this is a change in the way your gene is spelled that no one understands yet. It could be pathogenic, which is this kind of red looking bubble at the end here, or it could be totally benign, harmless, this green bubble down here at the bottom. There's just no way to tell yet. So it gets kind of plopped down here in the middle, this uncertain result. It can take years for science to figure out what an uncertain result like this really means. But at least half of these VUSs are later understood to be totally harmless and benign. Sometimes when you get a VUS back, and if there are other people in the family who've been diagnosed with HCM, it might be helpful to test them for that VUS. With the idea that if that VUS is actually the cause for the HCM in the family, everyone in the family who has HCM should have that same VUS. So sometimes that's helpful in helping us understand what the results mean a little bit better, but oftentimes it takes more than just one family to really help understand what the results mean. So the interpretation of genetic test results can really change over time. It's not common, at least at this day and age, for a pathogenic variant, this red bubble here at the end, to be downgraded to an uncertain result, or certainly not benign. If people were having genetic testing back in, before 2015, in like 2010 or something like that, it was certainly possible that there was something labeled as pathogenic that we actually now interpret as uncertain. But nowadays, it's pretty unusual that if you get a pathogenic variant or a positive result, that it'll change from that over time. But it's certainly very possible for an uncertain result to change with time. So it's important to stay in touch with your doctor who either ordered your genetic testing or with someone who knows about genetics and can help keep updated on what your results mean. Sometimes the genetic testing labs alert your doctor that ordered the test that there's been a change, but they don't always do that. And even when they do that, if you no longer see that doctor who ordered the test, if you've moved and then didn't update that doctor about your change of contact information, or even if that doctor is no longer with that practice that where the test was ordered, sometimes that information does not get passed on to you. So we always encourage everyone who's had genetic testing where the results were inconclusive to touch base periodically, every 3 to 5 years or so, with either the doctor who ordered the genetic test or a genetics professional, to see if there have been any updates. It's always something good to do. And in our clinics, for all of our patients who come to see us and who follow with us periodically, we do check on the interpretation of the results like this. And so we do routinely update people when we get results updates. This is just an example of what a genetic test result might look like if you've never seen one before. So this is an example of a positive genetic test result where there was a pathogenic variant identified in one gene. This person also has one of those inconclusive results in another gene, which is not an uncommon thing to see. Even though for most monogenic or Mendelian HCM, it's really just one mutation that's causing that risk. We can see other variants that we don't fully understand in them too. It's pretty unusual to have more than one pathogenic variant causing HCM in a family though. That's pretty unusual. So onto the kind of the next topic here, which is when should we consider doing another genetic test for someone? Generally speaking, if you have an abnormal or a positive genetic test result, there's not a need to do updated genetic testing. But as for people who've had inconclusive or negative genetic test results, certainly it's something to think about. Over time, we've been doing genetic testing for HCM for probably 20, 25 years or so, maybe a little more than that. And back then we were testing for just 2 genes. Now we test for over 30. And so we've certainly come a long way in our understanding of the genetics of Mendelian HCM, but we're still adding more. Like I feel like every few years there's a couple more genes added to the tests that we currently do. And certainly technology has gotten better. So retesting can really be helpful for people, but when should we think about doing it? And really, there's no clear guidelines on when to do it. Generally, our approach is that if we're really suspicious that someone has Mendelian or monogenic HCM, like they were diagnosed at a really young age, or they've got a family history, and their previous genetic test results were either negative or inconclusive, and it's been at least 5 years since they've had genetic testing, then we consider offering them updated genetic testing to see if we can find that genetic cause that we didn't before. Certainly, oftentimes when people have inconclusive or negative genetic test results and they say they contact us in 3 to 5 years or so to see if there's any updates, it's also a good time to check in to see if there's any new genes that might be worth retesting for. So I believe that's the end of the slides that I had for everyone. Certainly happy to take questions.
We do have a very questiony group here this evening. So now I have to kind of go through them for the genetics questions. We just completed genetic testing for my son. He tested positive for TNNI mutation and a VUS for, I have my glasses on, PDLIM3. Is there any correlation between a pathogenic TNNI and a VUS for, we'll just call it any other gene? What does a VUS mean in that context?
Yeah, so, and this is the tricky part too, right? So that gene in particular, the one where there's the VUS, that's a gene where there's not a lot of evidence to say that it's associated with HCM at all. So kind of one of these earlier, kind of preliminary evidence genes that some of the labs call them, where they differ from the tried and true HCM genes like TNNI3, MYBPC3, MYH7. These are some of the tried and true HCM genes. So if we see a VUS in a gene that doesn't have a strong association with HCM, it's going to take many, many, many years to understand if that's at all relevant. And my guess is a lot of them probably will not end up being that way. But with a result like that, usually it's just, like I said, one mutation, one pathogenic variant that's driving the development of the disease in the family. And so usually the TNNI3 is going to be the major kind of genetic risk factor.
Okay, you kind of went over this in your talk, but I'm going to just clarify it for this anonymous questioner.
Mm-hmm.
If you had genetic testing, 10 years ago, and we know that there's new ones, is now a good time to retest if it was 10 years ago?
Yeah.
And are insurance companies paying for it or not?
Usually, yeah. We're not having a whole lot of trouble with getting insurance companies to pay at this point. And, even I realize that, every family is a little different, but, a lot of the labs now offer genetic testing to people, like if deductibles are high and cost is going to be really high, a lot of places will offer genetic testing to people not through their insurance for about $250, which is fairly reasonable for a lot of families. At least it's much more reasonable than it used to be like 10 years ago when it was like $3,000 or $5,000 or even more than that. So cost is certainly much more reasonable now. So I'd say, yeah, it's a great time to get back in and see if there's anything new to do.
To date myself, 2005, when the first clinical genetic test became available, 3 genes,
Yep.
$8,000 to $11,000.
Yeah.
And I said, I'm going to go to work beating these people up on price. We got it down to $250, people. I'm from Jersey. There might be some bruised people in the lobby. Okay. HCM is serious. You got to have some fun when you can. Okay. You're welcome for the answer. So I've answered the answer. should extended family members like nieces and nephews get tested even if the sister shows no signs of a gene?
So no signs of a gene. So the tricky thing with genetics and HCM is that not everybody who has a genetic predisposition for HCM will actually develop the disease. And so it is possible to have a totally normal heart, but still have the genetic predisposition, even as an older person. And so if that sister has had negative genetic testing for the known cause of that HCM in the family, then her kids don't need to be tested. But if she just had a normal echo and never had genetic testing, that doesn't necessarily mean that those kids couldn't still be at risk. So it kind of depends on the situation.
Okay, so this is the 2-minute warning to Anjali to come on camera because we're going to go to your talk next. One more question on genetics and then we'll go to our next talk. I've been trying to find a connection to me having HCM. No one in my family, except for possibly a grandfather who died from what is written up as a heart attack in 1960, air quotes. That's the only family connection. Was the HCM discovered by the medical community? Question mark. I don't understand that question. What? When was HCM discovered? I'm sorry, I read that wrong. Probably should wear my glasses when I do this. The first diagnosis of HCM in the United States was 1959, September 16th to be exact, and his name was Claude Brady, and it was diagnosed by Eugene Brunwald. So 1960, having somebody die of, quote, a heart attack, you'd have to look at all of the circumstances surrounding it, his age at the time, what happened, was it witnessed, was it not witnessed, did he die within a few moments, or did it take days or weeks? There's a lot of variables that we look into when we're asking family heart health histories. So you'll want to get a little bit more information. Genetically speaking, is there anything you can do with that, Jessica?
Well, I was just going to say that, because I just said, that not everybody who has a genetic predisposition will develop the disease. It's also very true that you sometimes don't know you have HCM unless you look for it, right? That it doesn't often give you symptoms or signs. And so unless family members have had echoes, have had good screening, who knows what people have? And so having a negative family history can mean not a whole lot sometimes for people, especially when family members haven't gotten checked out. And your family history changes over time. And so not having a clear family history of HCM does not mean that there isn't necessarily a genetic cause for it, because HCM is tricky.
So I have to give my apologies. I forgot we have a new feature in the Zoom room that we can do closed captioning to those who might have a hard time hearing us. And I forgot to turn it on at the beginning of this session. My apologies. If you're watching on Facebook, it's probably streaming there with closed captioning, but it may not have happened in the Zoom room. Okay, Anjali, you're up next, but we're going to do one last question here. Does a certain HCM gene mutation have a higher likelihood of going into heart failure or transplant?
Great question. Not that I can think of off the top of my head. I think we need to get a little bit more data too about what different variants do. I think it's really tricky to get really granular about what different variants and different genes do in terms of risk for even things like sudden death or even just general prognostic information. And a lot of it's tricky because there's a lot of families where they might have what we call like a private mutation where it's only in their family and it's not in a lot of other families. So you don't have a lot of data to be able to say for sure if there's one mutation that's causing more of one issue than another as it relates to HCM. So not that I can think of, but it's possible.
Okay. Now we're going to get into, there's been a bunch of questions already. Tell me about the new stuff. Tell me what's coming. I'm like, we'll get there, people. We'll get there. So Dr. Owens, tell us what's happening.
All right. I selfishly saved this section for myself because we are very interested in what is coming, novel therapies, clinical trials. So I will spend a few minutes talking about those two issues. Let's see if we can advance the slides here. So the first one will be cardiac myosin inhibitors, or CMIs for short. And what are cardiac myosin inhibitors? How do they work? So this is the first therapy that actually targets the underlying problem with hypertrophic cardiomyopathy. And that is exciting because all of the other medicines that we're currently using were developed for some other condition, but we use them because that's the best that we had. And now we do have therapies that are targeted for HCM. And what do I mean by that? Well, what we think is wrong with HCM patients' hearts on a microscopic level is that the main contractile unit, so what's in your heart muscle cells and tells the heart muscle cells how forcefully to squeeze or to contract, is something called the sarcomere. And at that level, what we think is happening in patients with HCM is that there are too many connections formed between the two fibers that tell the heart how hard to beat. And so because of that, HCM patients have hearts that beat too forcefully and they don't relax normally. So you have a heart that's working too hard. And what this drug class does, the cardiac myosin inhibitors, is it reduces the force of contraction. So it reduces those numbers of connections between the fibers so that the heart goes from beating too forcefully and not relaxing normally to beating more normally and relaxing more normally. And that's the way that these drugs work. This drug, mavacamten, which is the first-in-class agent, was tested in a clinical trial called the Explorer trial. Many of you have heard of that. And Cynthia Waldman and I wrote a plain language summary, which is intended for patients. It's not for medical providers, but a patient level summary of this data. And there's a QR code if you're interested in looking at it. There's also a video that goes along with that. And so mavacamten, the first drug in this class, was tested in patients with obstructive HCM. And you'll remember the picture that Dr. Riza showed. When you have obstruction, you have a wall of your heart, the septum, that's too thick, that's pictured here, and it's harder for the blood to get out of your heart and get to the rest of your body. And we measure that obstruction by measuring a gradient, that's a pressure change, and we measure it by the echo. And so all of the patients that were in the trial had obstruction, they had symptoms, and they were all already on the best medical therapy that we had, which was either a beta blocker or a calcium blocker. None of the patients in the Explorer trial were on Norpace or disopyramide. But what we saw in that trial is the three things that you really want to see in your patients who have obstruction and have symptoms. And that is, they reported that their symptoms improved. We saw by testing on the treadmill that their ability to exercise improved. And we saw a significant reduction in that gradient number that we check to see how their obstruction is doing. And that's the way that mavacamten worked for obstructive HCM. So on the basis of that trial, mavacamten, which is the first agent in the class, was FDA approved in April of 2022. And many of you know that. It came out with a lot of fanfare because, again, it's the first targeted treatment that we have for HCM with obstruction. And so now patients with symptoms with obstruction can talk to their physicians about whether or not they're a candidate for this new therapy. Importantly, the FDA approved the therapy with what's called a REMS program, and that's for safety monitoring. And the reason we need to monitor your heart for safety is the way that the drug works. And you'll remember I said it takes your heart that's beating too forcefully and not relaxing to beating more normally and relaxing more normally. And when that happens, the obstruction goes away. But the risk is if you get too much of the medicine, then your heart may not beat forcefully enough. And that's kind of a continuum that you're on for how your heart is squeezing. And we watch that by the echo or the ultrasound. And Dr. Riza mentioned and explained what the ejection fraction is. So we follow that number. And when you're on mavacamten or other cardiac myosin inhibitors, we need to make sure that that number stays in a nice normal range and that it doesn't go too low. Importantly, what we know about this class of medications is that they're reversible. So if you stop the medicine or lower the dose, the ejection fraction will return to how it was. So you can talk to your physician because we are prescribing these medicines now. Here at our program, we have a mavacamten clinic where you come in, you meet your physician, you see our nurse practitioners, and we follow you over time as you come back for those safety visits and to see if you need more or less of the medication. The next in class agent, also a cardiac myosin inhibitor, is called aficamten. That medication is still in clinical trials. It's not yet FDA approved, but the pivotal phase 3 trial, which is the one just before FDA approval, if the trial is successful, is currently enrolling, and that is called the Sequoia HCM trial, listed here. There are many sites around the world that are enrolling for this trial. It's competitive enrollment and it's happening now. So if this is something that you're interested in, I encourage you to talk with your HCM team or to go to a center that is enrolling and see if you may be a candidate. This next trial is going to be Maple HCM. That's another trial of aficamten for patients with obstructive HCM, and we'll be enrolling soon for that trial. We're actively enrolling in Sequoia. So if that's something you're interested in, you have symptoms and you have obstruction, you may be a candidate for the trial. So what about cardiac myosin inhibitors for non-obstructive HCM? And you'll remember from Dr. Riza's slide, these are people that don't have obstruction, they don't have a gradient. We've had one small trial called Maverick HCM, which was looking at mavacamten in non-obstructive HCM. That was a dose-finding trial. So you do the smaller trial first, you make sure it's safe, you find a good dose range, and then you move on to a bigger trial. So the bigger trial is now enrolling. We'll soon be enrolling at our site, but there are other sites around the country that have just gotten up and going. This is the Odyssey HCM trial, and it's for people who have symptoms and people who do not have obstruction. That'll be ongoing. So the next thing I'll talk about is gene therapy. Gene therapy is a very novel investigative approach to see if we can treat genetic heart disease. Now, gene therapy over the last 10 years or so has really been promising and successful in some other areas, but this is the first time that we're really going to have trials for genetic heart disease and gene therapy. And I'll just show you a schematic here of the way gene therapy works. We use a construct or a vector, and that's called a viral vector in this situation. We remove the virus's DNA, and Jessica talked to you about what DNA is. That's the blueprint that tells your body how to make all of the organs. And instead, insert a working copy of the gene that is malfunctioning or abnormal in the patient with HCM. So you have to know what gene problem you have before you know if you're a candidate for gene therapy. And once the working copy is inside this vector, then it's given to the patient through an IV, through an infusion that goes into your body. And importantly, we need those cells to then get to your heart muscle. They've got to get into the heart muscle. This is harder than it sounds. And they've got to deliver that working copy of the gene where it's needed inside the cells of your heart. And again, this is a little bit trickier than it seems on just a schematic. And then ideally what happens is that working copy restores the gene to function properly and may improve your heart condition, or maybe in some time in the future, even be a cure. So we have a number of challenges to overcome. Some of them are listed here, including getting high enough levels in the heart so you get enough protein expression. Importantly, we have to avoid the immune system response. So your body is primed to react to something that's not yours. And so when it sees the viral vector coming in, you can get a response to that can be serious. And we need to be careful about the safety of these kinds of therapies and make sure that it's safe for patients and monitor them. We usually need to suppress the immune system, which is giving medication so that you don't have that reaction. And those medications are generally temporary. And we need to understand more about whether this is durable in the long term for humans. So not without challenges, but I think that we will see commitment from various biopharma companies to bring these therapies to patients. So within the next 1 to 2 years, we expect to see the first in human clinical trials, starting with hypertrophic cardiomyopathy that's related to abnormal changes in myosin binding protein C. So in the coming years, it's going to be really important for patients to know their genotype so that we know whether or not a therapy can be targeted to an individual. And this is taking us to a whole new realm of targeted therapies for HCM, which is very exciting. The last thing I'll talk about are cardiac mitotropes. That again is a novel class of medications that are really meant to improve the way your heart utilizes energy. We know the heart uses a lot of energy, the most energy of any organ in the body. And when your heart's not utilizing energy normally, it's being inefficient. We see that in patients with HCM. And so the Improve HCM clinical trial is for patients with symptomatic non-obstructive HCM, and it's to investigate a novel agent, which is listed here, to see if that agent can improve symptoms, quality of life, and exercise tolerance. So another clinical trial. How do you get involved in clinical trials? So here's where I want our patients to be proactive and understand that we need all different kinds of patients in clinical trials, all different kinds of HCM patients, young patients, old patients, non-obstructive, obstructive, various symptoms. We really need everyone represented. So ask your team if you are a candidate for any available clinical trials when you see them in the office. Reserve that last 5 to 10 minutes, which is what I do typically with my patients, to talk about what's coming and what they might be a candidate for. And know your HCM. So these are terms that get thrown around that if you understand them about your own heart, you'll know what you might be a candidate for. So do you have obstructive or non-obstructive? What is your NYHA functional class? And Lisa talked about this at the beginning. What are your symptoms? What are the results of your exercise test, your echo? And what's your genotype? And that will help us to know whether or not we can target specific therapies that are coming down the road. And there are a lot of them that are in development. They're all very exciting. And I hope that our patients will be able to get involved. I'm going to stop there. Here's a couple of pictures of the team.
You just love showing those pictures of your team.
Such a happy team.
It's a happy team, and it's a good thing to show team pictures. You know what I think I'm going to do, as you are going to give Amy's talk
Yes.
on how to, get in touch and what to
Mhm.
expect during a visit. Why don't we pivot to that while you're in talk mode? And then we got a lot of questions piled up. We're going to do speed rounds. So as soon as she is done, rest of my faculty, please come on. Wait, where's Kim?
Kim
Oh,
is
no, I'm
here.
sorry.
She's writing notes, but she's ready.
I'm
Yeah.
sorry. I skipped a talk. Kim, I'm so sorry. So
I'm learning lots.
forget what I just said. Let's pause for just 1 second. I was a talk ahead. All right. So we do have some new drug questions, and we'll do these in as quick a time as we can potentially do.
The other
What
thing
is-
I could do is I could try to type some answers while Dr. Lynn is talking, whichever you prefer.
Let me ask a couple live, and then I'll let you do a couple in writing. And you can all read the written questions. And there've been so many questions tonight. We may take the written ones and distribute them to everybody after the session. We'll take everybody's names off, of course. What is the intended purpose of mavacamten? Will it treat AFib, heart rate, coagulation? I have non-obstructed HCM and been in AFib for years.
Wonderful question. The intended purpose is really to normalize the contractility of the heart and improve relaxation. Now, if you take a heart that's stiff and thick and not relaxing, as Dr. DeFeria showed you, that state over years can lead to enlargement of the top chamber due to back pressure and lead to atrial fibrillation. So in theory, if you get a heart early enough in that disease process, perhaps we would see less atrial fibrillation down the road with treatment of these drugs, but we don't have that data yet. It's too early to say. We're just gathering that data in the long-term extension of these clinical trials as patients remain on the drug for 3 to 4 years. At our center, we have people out about 4 years. What we have seen is that when we look at the structure of your heart and we look at by MRI and by echo, we see the left atrial size going from enlarged, which is typical of a patient with HCM, over months and years. The left atrial size is coming down. It's improving. So we're seeing some what we call structural remodeling benefit that over time may translate into less atrial arrhythmias. But again, we don't have that data yet. It's too early to say. So we need patients to be followed for a longer term so we can see what's going to happen.
The non-obstructed arms of the myosin inhibitor studies, when will they be loading non-obstructed patients?
So the non-obstructive patients will be in the phase 3 Odyssey HCM trial. That's going to be for non-obstructive patients. And we will get long-term data once those patients are in the long-term extension. The small Maverick trial, which was that dose finding trial, had 50-some patients in it. We do not have MRI data, but we are gathering long-term data from those patients who are in the long-term extension.
Okay, last question, and then Dr. Lynn is up.
Yeah.
Can't believe I almost went past that one. Bad me. Have there been patients with preserved ejection fraction who took a myosin inhibitor and dropped their ejection fraction enough that they ended up in heart failure with reduced ejection fraction?
Yes, and that is why the safety piece is really critical, because you can get too much exposure to the drug and drop your ejection fraction below 50. That has happened in the clinical trials and it's happened in real life. And what you need to do is stop the drug, let the ejection fraction come back up, and then restart the drug potentially at a lower dose. The other time that we see this happen is if someone gets some other kind of illness while they're taking a cardiac myosin inhibitor. And you can think in your mind that it might make sense that if you get a really bad pneumonia, you get really sick with something else, or in our HCM patients, you get really fast atrial fibrillation, where you might need a little more of your squeeze back. And so if you're on a medicine that is governing how much you could squeeze, that maybe you'll have a drop in ejection fraction. We see that in patients even who are not on cardiac myosin inhibitors who get AFib. And so what we need to do is be vigilant of that. And if you're on one of these therapies, you got to reach out to your team and let them know, I'm back in AFib, I have pneumonia, I have a urinary infection, so that we can modulate or change your drugs if needed. What we have seen though is that the effect is reversible. So if you stop the medicine, then the ejection fraction goes back to where it was.
Perfect. Okay. Now we're going to switch to the kiddos when they get a little bit bigger, maybe. All right. So now we're going to talk about our pediatric and adolescent population and that transition period, transitioning from a kid to an adult with HCM. So the pediatric cardiologist has done their job. We've gotten to adulthood. Now they hand you off.
Thanks, Lisa. Thank you for giving me the opportunity to speak tonight. I think as many of you heard before, I'm Kimberly Lynn. I'm the medical director of the cardiomyopathy program at CHOP, which is the Children's Hospital of Philadelphia, and a faculty member with the University of Pennsylvania, along with the other physicians who've been speaking tonight. And I'll speak hopefully briefly about that transition from pediatric to adult care, hopefully specific to what you guys all are interested in, which is cardiomyopathy care. So when I'm talking about transition, just to be clear, I'm talking about the purposeful and planned movement of folks in that adolescent and young adult age group who have a chronic condition, physical, medical condition, going from child-centered to adult-oriented healthcare systems. Just to be even more specific, sometimes we talk about transition and we really just mean transfer and vice versa. So to be clear, the goal of just a transfer is that we get a young adult to attend an appointment in an adult healthcare system. But really, I hope that at least at the end of these few minutes, you'll all be convinced that we really ought to be working to transition young folks from pediatric to adult healthcare, and really not just trying to get them an appointment and get them to adult healthcare, but also moving with a knowledge set and skill set to be able to navigate their own healthcare, or figure out how we incorporate their helpers into navigating and advocating for them as they go from a pediatric centered care to adult centered care. The abrupt transfer of care, which I hope none of you or few of you have experienced, that can negatively impact the health of young adults. And you'll know there's a lot of variability between programs. Some programs are more flexible than others about the time of actual transfer, but all programs can really anticipate and help plan that transition process. So you may have a child, or you may be a young adult who's been at a pediatric center that has a very hard age cutoff. Other places, don't have an exact age cutoff or have a later age cutoff. Any center, though, can be anticipating that and helping to think about transition of care and not just transfer. I do often get the question, why can't I or why can't my child just stick with my pediatric care provider? And really, there are a few things to take into account there. One is that really does conflict with developmental norms of adulthood. And it sends the message that young adults really aren't capable and won't be capable of self-management. Also, it's important to recognize that pediatric providers like myself are not ideally equipped to deal with adult medical issues. For example, we try to remember to talk about reproductive health issues, but those are things that that really do need to get addressed in an adult-based healthcare system. And then just sticking with the pediatric care provider does ignore the lifelong risks inherent to cardiomyopathy. We're on a journey. It's a long-term journey, and we don't just want to stick with the pediatric mindset. So when should a person be capable of self-management? Again, this is going to be, in most cases, a gradual and planned, hopefully planned process. And at what age that occurs and how this happens can be quite variable. It's important to take not just a person's age, but also their developmental level and their readiness into account. And really remember that self-management is an important component of a successful adult care of a medical condition. So self-management, what might that look like? And what are some of the landmarks that a young person can see and start to tangibly identify on their journey in a successful transition? Well, they want to be moving towards independently following a medication regimen, learning how to call in their prescription refills or even recognize when a prescription is going to run out and that they need to get in touch with the pharmacy or their physician to get a refill. Start to ask the medical team questions about their health condition and their self-care, schedule their own appointments, learn how to seek out information about illness and maintaining wellness, start to potentially see medical providers alone if that's appropriate, know about and follow healthy nutrition habits for their condition, and even as we talked about earlier tonight, healthy exercise habits, planning for school or trade or eventual profession. And then eventually also start to understand health insurance and make sure we're talking about issues related to sexual health and reproduction. There have been some folks who've tried asking adolescents, what's important as they prepare for adult care, and they often tell us they need more information. They often really want peer support, and they also want adult mentorship from folks who've been through this already, and seen some of the hardships and also been able to successfully get through that transition. And after transition, looking back, young adults have told us that they wish they had several things, that they'd heard more about the long-term implications of their illness, learn more about employment and what's possible and what might be hard, learn more about insurance, family planning, and also about mental health concerns and how to address those. Many of you on tonight's webinar, I'm sure, are parents, and what sort of things could you be considering? Your role is still going to be really, really important, but just we have to recognize that it's going to start to be different, and you're going to move from being in control, or at least feel like you're in control or should be in control, to being a good cheerleader and an advocate and helping your child and your growing and now adult child to be an advocate for themselves. So this is a graduate shift from control and all of the decision-making to teaching skills and empowerment. And eventually you'll be more of a consultant rather than a driver in your loved one's care. And the key here is likely starting small and starting to do this in small chunks, and acknowledging it often can't be done all at once. I did want to put another plug in for our program in particular. So the Penn Chop Joint Familial Cardiomyopathy Program was established back in 2011 as one of the first truly joint clinical programs for cardiomyopathy families. And this was established between Penn Medicine and the Children's Hospital of Philadelphia, and really staffed by a lot of providers who are faculty members in a common institution, the University of Pennsylvania. We pride ourselves in providing cardiomyopathy care for adults at Penn and children at CHOP. And as a group, we have monthly meetings of our team members, including cardiologists, geneticists, genetic counselors, allied health professionals, nursing, and often we bring in guests to help us with imaging and other aspects of understanding and furthering the care of folks with cardiomyopathy. And we do have a growing group of patients who have successfully transitioned from CHOP to Penn. So again, I just wanted to put a plug in for that. It's always nice to know that, when I have a child who's been diagnosed newly with cardiomyopathy, that I know of a really strong group to be able to refer their parents and their adult siblings to, and vice versa. When someone comes and has been diagnosed with hypertrophic cardiomyopathy at Penn, I know we often get the chance and the opportunity to meet the children of those new patients and make sure that their kids are looked at in an appropriate manner early and as often as they need to be. So in conclusion, transition planning is a necessary part of clinical care for adolescents who have lifelong conditions such as hypertrophic cardiomyopathy. This process should be a collaborative effort by those adolescents, by their families, and their healthcare providers. This is a process that should take place over time, starting early in adolescence, and really transition promotes health into adulthood, and the Penn CHOP Joint Familial Cardiomyopathy Program is one potential home for your lifelong cardiomyopathy journey. Thanks.
Those are so on point. As a mom of a now 27-year-old, it's a complicated path to hand over responsibility for oneself to an adolescent mind who doesn't fully understand all of the implications because they're still kids. But I will say I probably did a lot of things right, and I probably did a lot of things wrong too. As we're parents, we're flawed. But I actually started to engage with my daughter when she was deciding to get a device, to ask her own questions to the doctors, to break down that barrier that she wouldn't feel comfortable speaking to them. And boy, did she speak her mind to them. So
I wonder where she got that from,
I
Miss
have
Solberg.
no idea. We're so meek and mild in my household. But she learned how to be a bit of an advocate for herself. I wish I had a better appreciation for the mental health strains on adolescents with HCM back then. Even though I was a kid with HCM, I maybe denied part of the experience. So I think you've laid out a perfect playbook here that we need to develop better services for these kids and help them transition more. So we will be taking this talk very seriously and really breaking it down into some of those elements and creating some tools based on this. So thanks for the playbook. We don't have any particular questions yet, but I'm sure they're going to be populating in a second. And our fantastic faculty has been quick at the keyboards trying to keep up with your questions. Congratulations, UPenn. You have the most questions ever in a Bighearted Warrior tour. So we're trying desperately to keep up with them right now. Here's a question. Nope, that's an advanced heart failure question. Okay. So Anjali, I'm going to have you come back and give us that final talk, and then we'll go to full Q&A. So if you have any questions about pediatric or adolescents, now would be the time to post them so we can address them in the final session.
All right, here I am. I think, Kim, if you stop sharing, then I'll start.
I can make her stop.
Okay.
I have made her stop. Now you may share.
All right, here I am. So for the last segment, I am not Amy Marzoff, who is my fabulous nurse practitioner, but she's not here with us. So I'm going to tell you a little bit about what to expect when you come to our center for your first visit. And we'll just run through a couple of slides. So number one, how to make an appointment. How do you reach us? Here is our phone number in bold and red. This is our clinic. It will be answered by one of our call center or administrative staff. They will direct you to our program scheduler, and they will ask you a few questions, including your diagnosis, who are you currently following with for a cardiology team, what teams you've had in the past, and what previous testing you've had. And this is important so that we can gather all the data ahead of time. So even if your cardiologist says, I want to refer you to Penn, or it's a series of emails back and forth between providers, we always like you to have this intake call so that we can get the information. When we think about what we need and what we want you to do before your appointment, we usually like you to take some time to think about gathering your old records, thinking about chronicity and the timeline of your diagnosis and your history. We start at the beginning, as you'll see when we come here. What was life like as a kid, teenager, through your adult years? So think about that. And then also try to gather some of that family history, because we always have you meet with one of our genetic counselors as part of that initial visit. And we like to gather that data. Some of our genetic counselors may even reach out to you ahead of time so we can start drawing your family tree. Gathering that data is important. Coming to the Perlman Center, this is where we see the vast majority of our patients. Dr. DeFeria is seeing a few patients out at the Radnor office, but the vast majority of our clinics are here in the Perlman Center. If you call the main hub number, the Penn number, there are a lot of different Penn centers, clinics, hospitals. Our HCM Center of Excellence is run through the Perlman Center, and that is the place you should be coming to meet our team. What will happen when you come, prepare to spend some time with us. So we always say the first visit is the longest, and we set aside about an hour and a half. So prepare to spend that amount of time with us as we review all of your history. We talk with you about what the plan is going to be going forward. You'll meet our genetic counselors, you'll meet our nurses, you'll meet your physician. So prepare to spend some time. Our genetic counselors, as I already mentioned, will visit with you. If genetic testing is appropriate, we'll think about doing it that day. If screening of family members is appropriate, we'll talk to you about it that day. Gathering that family history is really critical. And I think that's probably it, because you've already met our team. This I've already shown you, which is our physicians. And here's a full pictures of our nursing staff and our genetic counselors. So I will stop there. Lots of pictures. Lots of professional women, as you will see here, in medicine. And Alex.
This is very much a strong girl team.
Yes, it is.
We got the guys there too, but it's not as common to have a predominantly female team.
And there he is on camera, just to show that he is a male of our team.
And we appreciate that. We like that camaraderie. Okay. So we've answered a lot of the questions in the chat. So if the rest of the faculty wants to come on, there's just a couple that we're going to clear up, and then we're going to stop streaming in just a minute. Have you seen any reduction in existing scar with long-term myosin inhibitor therapy?
Wonderful question. There's going to be data presented at the ACC, which is the next major meeting in March, about MRI in the 96 week MRIs from Explorer. So there will be some data presented. I will say that we don't know what the natural history of progression of scar is in HCM. We need that data, just natural history data. What does your heart do typically on average in order to have a comparison? So it may be hard to know.
Okay, so there was a question I asked for more data, but I didn't get it yet. Somebody has a child who's recently diagnosed and they're military and they travel around a lot. Are there any tips to offer a parent who is going to have a variability in access to care? Are there telemedicine options at centers that they might want to utilize for some continuity of care or other strategies?
I wonder if Kim might take that one.
So I think it's evolving. I think that the availability of telemedicine has overall been really helpful, but the rules keep shifting on where telemedicine can and can't happen. So I can't give a very specific answer to that, so much as it's worth asking, right? I mean, there is some value, I think, on both sides for the providers and for the patient to be able to see someone in person, but we've been able to accomplish a heck of a lot, with remote technology. So it's worth asking.
Anybody else have comments on? I would expand that to, we have a number of active military families where a family member is the one that's diagnosed. They're not the active military person, but they're a spouse. And they have some challenges traveling around. TRICARE tends to pay for, they may pay for travel to a center, depending upon where you're located in the world. But it can be challenging. Have you guys dealt with any of this and any tips?
We have a few patients in the military, and I can't say we have great tips, but we have been able to work with TRICARE on providing care and maybe doing a remote visit for the 6-month visit and then an in-person visit for the yearly visit. So kind of alternating and then, just doing your testing on that in-person visit once a year.
Okay, I'm going to ask this question, and at the conclusion, Facebook, we're saying goodbye and we're turning off recording. But I think this is an interesting one that people might be interested in. Related to myosin inhibitors, how do you differentiate the PK profiles between MAVA and aficamten? Anybody want to play with that one?
What I'll say is that mavacamten has a longer half-life than aficamten. And because of that, we have different titration strategies. You need to titrate a bit more slowly and allow a patient to get to the steady state before you change the dose, as opposed to aficamten, which has a shorter half-life. And so you can change the dose more rapidly. I think that's probably the data that we have at this point, and more data will be coming as we get the clinical trials underway and concluded.
Okay, Facebook.